So, welcome to CVS Health Live. On CVS Health Live, we address perspectives and insights that are dealing with health issues that are important to us now. Today, we're going to be discussing COVID-19 vaccine hesitancy, and I'll be discussing that with Marcella Ryan Harris, who is the co-founder and director of strategic partnerships for an engagement for Black Health. Now, keep in mind that is BLKHLTH. Want to make sure you get that right. And I also have Dr. Georges Benjamin, who is the executive director for the American Public Health Association. So, Marcella, Dr. Benjamin, thank you very much for joining us today.
Thank you.
Glad to be here.
Glad to have you. So, the first topic we're going to address is understanding the history of systemic racism in America. We've talked a lot about the distrust of the COVID-19 vaccine and many other matters related to healthcare. We know those things didn't start overnight. So let's start off our conversation, if you don't mind, by taking a look at the history and some of the things that have led up to where we are today. Now, we kind of hear two stories right now. We hear a story of hope and optimism about the COVID-19 vaccine, but we also hear a story of hesitancy, particularly in the Black and African American community. So, Marcella, do you mind sharing with me or providing an overview of how racism has been perpetuated and how it manifests itself currently in our healthcare system?
Yes, thank you so much for that question, David. I think one thing we have to know is that I feel like a lot of times when you hear the word racism, people think it has to be like this overt hate speech, hate crime, violent action. But really, racism has been ingrained into the social, economic, and political structures in our society. And so it perpetuates itself because our systems are inherently racist. And they weren't designed to really support all the people that exist now in our society. And so we see racism impacting the health of Black people just on a physiological level through a phenomenon called weathering, which is just that chronic stress that is on our bodies due to racism that impacts our health outcomes. And when it comes to the healthcare system, we see Black people have poor access to healthcare, they receive poor quality care across the spectrum. And recent studies have shown that white medical students, have biases against Black patients. They don't believe they feel pain in the same way as their white patients do. Emergency room doctors are less likely to admit Black children to the emergency room or to the hospital who complain of the same symptoms as white children. And Black patients are also less likely to be admitted to the hospital than white patients. And that is just all because of these structural barriers that we see in the healthcare system due to racism.
Marcella, I think you hit the nail on the head. There are often so many times this misunderstanding or different viewpoints on what racism actually looks like. It's not always burning a cross or someone wearing a hood. It can be systemic decisions and systemic approaches to healthcare that aren't necessarily as blatant to the untrained eye as to what the negative impact and the disparate impact can be on the Black community. So thank you for helping us kind of really think through that distinction there, if you will. Dr. Benjamin, we talk a lot about the Tuskegee experiment and the impact that that's had on the level of mistrust and distrust in the Black and African American community. How far back do these practices go? Things like the Tuskegee experiment, and what is the lasting impact on the Black experience in U.S. healthcare today?
Well, I think the important thing is to go back to slavery, when African American women were often part of experiments. People did things to them in terms of experiments around trying to find out whether or not a particular therapy worked, and they often did that using African Americans as their subjects. And then we had, obviously, Tuskegee, which is often talked about. And for many people, Tuskegee was a fascinating, terrible study. It was a natural history study, which was following the course of a disease called syphilis. Syphilis is a sexually transmitted disease. What made this study so egregious was, first of all, they didn't tell these gentlemen that they had a sexually transmitted disease. So they were continuing to have, obviously, sexual relations with their sexual partners and, of course, infecting them. And then when a treatment, penicillin, by the way, became available, they were not offered the treatment. They were not informed that a treatment had become available. And that study persisted until the lid was blown off by a person actually at the Center for Disease Control and Prevention and a reporter. Now, it has often been misinterpreted that these men were given syphilis. And the real harm there, of course, in addition to not informing them, was the fact that they were not treated. And I think in many ways that is the historical harm that we saw from that study. Now, many things have happened since then, and we've had the Henrietta Lacks story where Miss Lacks' cells, which were found to basically live forever, have been used in research. And the big harm there, of course, was that her family was in no way compensated due to the fact that many people made money on it, but her family did not. You know, as we go forward in today's experience, yes, those other things were historical in nature, but as Marcella said, you know, it's about how we were treated yesterday and people's experience, which basically in many ways serves as a verifier. It reinforces those historical wrongs that we saw many years ago. And so it brings those harms back. So when you were mistreated, you were not provided access to health care. When someone told you you didn't have pain when you really did. When someone said, you know, we could hospitalize your kid, but I don't think we're going to do that now. And you know that the reason they're doing it is based on race and the idea that they really don't feel that you're deserving of being hospitalized. Those kinds of experiences and feelings are what makes the hesitancy we have today and the distrust we have, both in the medical system and within government.
You know, you bring up some great points there, and going back to the days of slavery. We're talking about 400 years of an experience in the Black and African American community. And you're also talking about, even though it does go back to the days of slavery, this is not ancient news for us as a community. You know, my father, who's now passed away, was born in 1926. You know, this was his generation who experienced, you know, the Tuskegee experiment and you know, the Henrietta Lacks story, the involuntary sterilization of Black women in the South, you know, that happened as late as the 70s. You know, this is not all ancient history, but, you know, your point that it goes back to the days of slavery is an important one, because that is a long-lived experience of these kinds of issues when you think about 400 years. You know, Dr. Benjamin, as a follow-up, when you think about research, do you think that, you know, there's racism as it relates to research? I mean, you know, you talked about some of these experiments being done in the name of research. You know, you think about research today. You know, I know some folks felt, you know, somewhat comforted, maybe I'm wrong in that, but, you know, looking at Dr. Kizzmekia Corbett having a role in actually developing this vaccine, I think it was nice to see representation from a research perspective, but from an overall scale of, you know, 1 to 10, I mean, where do you think racism plays a role in research as it stands today?
Well, I think as Marcella tells you that it's integrated into all of our societies, and so it certainly exists. But several things have been done to try to minimize the ability for racism to occur. And that is by having these oversight boards and review teams and rules and regulations in terms of informed consent. All of those things are put in place as a way of trying to rectify the lack of misinformation that people got, the lack of information that they got to begin with. Also trying to engage more African Americans in research studies, because we all know that all of our bodies aren't the same, and therapeutics and procedures may impact different people differently. But having said that, we still do not have enough African Americans involved in research. We still don't have enough African American patients in the research studies, nor do we have enough African Americans on the study panels. And so when you don't have those things in place, then people bring their life experiences to the table as they evaluate studies, as they decide where the money is going to go, or they decide where the research programs are going to go. And when you don't have everybody represented in the room, then the money and the programs go to the people that are in the room. And so we need to do a much better job of making sure that academic researchers are involved in every aspect of these studies, and that includes people of color.
Yeah. And I think that will go a long way as well in breaking down that barrier of trust or distrust. I remember when my father was very ill towards the end of his life, many doctors wanted to enroll him in clinical trials. And my mom, because of our history with the U.S. healthcare system, would say every single time, they're not going to experiment on my husband. You know, you're not going to run any experiments or tests on my husband. So there's still this strong level of, clinical trials are not for us because you just want to use us as guinea pigs. So we're not going to do it. That's something major we still have to deal with. So let's talk about, where we are in the present with the COVID-19 vaccine. Dr. Fauci has said that we need to vaccinate about 75 to 80% of folks in the country to get herd immunity. Yet we know that there is a strong hesitancy among blacks to actually take the vaccine. As a matter of fact, a study conducted by the COVID Collaborative and the NAACP found that only 14% of Black Americans actually are willing to take the vaccine. And we know from our own research, we did a study back in November, and we followed that up with a study in January. We know from our own research that we've seen a 9% increase in the percentage of Black Americans who are not willing to take the vaccine when it's available. A 9% increase over 2 months. From the start of these conversations to where we are now, we're seeing it go in the wrong direction of Blacks and African Americans who are willing to take the vaccine. So Marcella, could you share with me what you think some of the contributing factors are specific to the vaccine that are driving some of the hesitancy in the Black and African American community?
Yes. Well, I think, much to what Dr. Benjamin was speaking about earlier, the government and the healthcare system just really hasn't proved themselves to be trustworthy in Black communities. So I think that really contributes. So those historical instances, and then even the things that we see today as it relates to COVID-19 and vaccine distribution, really just further hammer that home for a lot of people not to trust it. Access to care is still a really big problem when it comes to vaccine distribution. I've heard a term floating around recently called vaccine redlining, where white affluent communities are, receiving the vaccines at higher rates than Black communities who really, have been disproportionately impacted by COVID-19. And so, recent data from CDC has shown that 65% of people who have received 2 doses of the vaccine are white, and that's compared to only 5.7% of Black people. And the trends kind of are the same across all minority groups. And while some of that can be related to vaccine hesitancy because of distrust, a lot of that also has to do with just access. People can't access the vaccine. I know my mother is 66 years old and she's been trying to get the vaccine since January. She's been on a wait list. And there isn't even anywhere, near our community that is doing it. She has to go into the city. So while the distrust is there are still other factors related to structural racism that play into that as well.
Yeah, thank you for that. And hoping your mom can get that sooner than later.
Yes, me too.
Yeah, Dr. Benjamin, as you think about, these challenges, how do we dispel the myths or some of the concerns that Blacks and African Americans have specific to the COVID-19 vaccine, and who do we lean into as trusted voices?
There are 2 reasons that people are concerned about the vaccine. It's important to understand that in most cases, these are not people that are going to say, absolutely not, I'm not going to take the vaccine. But the idea is that about 43% of them are saying, I just don't want to be first in line. Give me more information. So it's about safety and efficacy. Now, we do know for sure that this vaccine is safer than getting the disease. This is a bad disease and one you don't want to get. We also know that communities of color, particularly African American men, Latino men, Native Americans, are much more likely to get this disease. And if they do get it, they get sicker and die sooner. So with that in mind, The millions and millions of vaccinations that we've done so far have demonstrated very clearly that this vaccine is safer than getting the disease. By the way you get these shots in the arm is you go into the hood. You take the vaccine to the patients. You don't make sure that the patients come to the vaccine. You may get an appointment much easier. If you can only get your appointment online, then the challenge you have, if you don't have access to a computer or you don't have Wi-Fi and broadband, is that you have to try to use a phone. And most of the appointment systems today are online computer-based. And that is important. I love computers, but for many people, that remains a challenge. For many seniors, that remains a challenge. Computers are great for our 22-year-olds, our 18-year-olds. They love them. Even my grandkids are very computer literate, but many of our seniors are not. And so if we make that as the primary way that you get into the system, then you might as well you might as well say you don't want them vaccinated because you created a system that they can't get into. So we need to go to trusted messengers. That are people that are in the community that people trust, leaders of faith, doctors and nurses, particularly doctors and nurses that look like the community, that have the language of the community, not only just in terms of a community in which English is not their first language, but can culturally, as they say, talk the talk. But I think at the end of the day, if you really want to know why people are hesitant to get the vaccine, then the first thing you ought to do is ask them what are their concerns, and then directly answer their concerns. Don't assume you know what their concerns are. Meet them where they are, give them the information, and I believe that in most cases, if you do that, then they'll become, as I say, moving from vaccine curious to vaccine confident, and then they'll take the shot.
Yeah. Thank you, Dr. Benjamin. I want to strike the right balance between the focus we need to have on COVID-19 right now and the vaccines, and we still have to do testing. That's not going away anytime soon either. We still need to do testing. So we're thinking about the vaccinators in that case. But if someone is dealing with another clinician or another provider that's not necessarily doing the vaccination, what can those providers do to help build trust and help dispel some of the myths for their patients?
Well, obviously we need to talk to our clinical colleagues and let them know about the science base behind this vaccine. One of the real surprises was the degree of concern that we had within healthcare providers to get the vaccine. And a lot of that had to do with the fact that they were not given the information. We, by the way, made the assumption that everybody understood the science. And that's just not the case. We have people that have listened to the misinformation that's out there, that may have not understood what they have been told. But we also made the mistake of thinking that everybody was the same. So, the information that you want to give to a RN or an ER doc is different information than you want to give to the nursing aide in a nursing home or an EMT or a paramedic. They all need to have that information, again, given to them through the lens in which they've been trained and their knowledge base. And the other thing is, once they've been vaccinated, then they can become champions for vaccination in the practices in which they have. And, one of the things we have not done is, while we've spent a lot of time and effort vaccinating people at these academic health centers, we have not done enough to vaccinate the community providers who are actually seeing people on the front line. We also need to use groups like other vaccinators, like pharmacists. Pharmacists can give shots. They give shots all the time. They're well trained, and they understand the side effects of all the medications that they prescribe. And so we're not using pharmacists enough. Physician's assistants, a lot of nurses that are retired, physicians and nurses. We can bring them in as vaccinators, but we've really not grown the workforce so that we have enough workforce as well to vaccinate everyone.
Yeah, it's a great point, Dr. Benjamin. And that's something we've invested in at CVS Health. And at scale, we'll have the ability to do 20 to 25 million vaccinations per month. So you're right. We need it. It's got to be an all hands on deck from an actual getting the vaccinations in people's arms perspective. Marcella, I know you come from a family of healthcare professionals. You're probably wondering how I know that, but I looked up your background, so did a little research on you. You come from a long history of healthcare professionals in your family. And I know at one point you were going down the pharmacy track yourself and decided to take a little bit of a different path and was part of the founding and starting up of Black Health for a specific reason. If you can both share with me where you would send individuals to get more information. I know Black Health is certainly one of those venues and one of those sources of information. Can you talk a little bit more about that property and some of the information that people can find there?
Yes, thank you. And yeah, you did some good research there. But yeah, so Black Health, as you said before, blkhlth.com. We have a lot of resources there. We also have a text message campaign for residents in the state of Georgia, where we send out COVID-19 tips and resources, information about the vaccine and testing sites as well. And we also point people to COVID-19 resources within their own communities. Because again, I think, we really have to reach into the communities. You have to meet people where they are. And so we really try to do that as an organization with Black Health, is really just connect people to the resources that are already out there that they just don't know exist.
Thank you. And I have had a chance to really do some clicking around and looking at the site as well. And it's very, very well done. So thank you very much for standing that up. And thank you for reminding our listeners and viewers where they can go to get that information. Dr. Benjamin, how about you? Where would you send people for more information on how they can dispel the myths around the vaccine or break down that hesitancy to get it?
Well, let me start by saying that trusted sources are very, very important. And there's a whole list of them. Certainly the federal government at the Center for Disease Control and Prevention, listen, they are a trusted resource. I trust them. And I would go there at cdc.gov. The American Public Health Association, my organization, apha.org, very, very important place. We've been around since 1872. And listen, we're a trusted resource. I would, go to the National Institute of Health to learn more about vaccines, or the Food and Drug Administration. Both of those organizations are the regulatory bodies and the science bodies that are actually doing the work. And if you want to get your appointment, everyone should go to their state health department's website and start there. Now, getting appointments is a challenge, and we know that, and we're pushing them to try to fix the appointment system so they're one-stop shop. But frankly, they're the most authoritative place for you to go in your neighborhood if you're trying to get an appointment. And we're hoping that very soon, as vaccine supply dramatically increases, that's a place you can go. And then finally, the local pharmacies. And we know that CVS and others are getting in the business and of getting vaccinations, and they're reaching out into communities to try to make sure that we have equal access to vaccinations. That's a very, very important thing that they're doing. I'm going to speak up for you and say, listen, Google your local pharmacy and see if they're giving vaccinations. Get into their appointment system. And when it's time for you to get vaccinated, I encourage each and every one of you to get vaccinated.
Thank you very much for that. And I'll tell you, we are prepared to, as I mentioned, deliver 20 to 25 million vaccines a month. But this is an all hands on deck activity. We need partners like Black Health. We need partners like APHA. This is going to take a well-rounded, holistic approach to get us on the other side of this vaccine and to whatever the new normal looks like. None of us really knows what that's going to be, but we know it's got to be better than where we are today. So we need partners like you, and we are doing that. We are reaching out to partners on the ground in the community, trying to figure out who the trusted voices are, activating those surrogates and those voices to get the word out into the community. Marcella, Dr. Benjamin, both of you mentioned access earlier. We have 10,000 stores where individuals can come to get vaccinated, but we know that still may not be able to reach everybody we really need to reach. So we're standing up mobile vaccination sites, pop-up clinics. We're actually rolling out a fleet of vans where we can take vans into communities for individuals to get vaccinated. But it's got to be both. It's that we have to have, the inventory in the right places, and people have to be able to access it, but we also still have to break down that barrier of trust. And I really appreciate you both taking the time today to help us understand where that comes from and what we can do going forward to mitigate that risk of our folks not getting the vaccine when they need it. So at CVS, you can find out more information about what we're doing. You can get more information on our vaccine hesitancy study at cvshealth.com. You can go under news and insights and articles, and you'll be able to download a copy of that study. And also, we have a COVID-19 resource center on the site as well, so you can get information. So please go to cvshealth.com for more information. Thank you all very much for tuning in to this episode of CVS Health Live. Please be well and be safe.